Association and the Texas Medical Association. We are honored to host Dr. Keiser, who serves as Director of the International HIV Program and Clinic at UTMB. Dr. Keiser earned his medical degree in 1986 from the University of Maryland School of Medicine. In 1989, he completed his training in internal medicine at the Francis Scott Key Medical Center in Baltimore, and then returned to the University of Maryland School of Medicine to finish training in infectious disease in 1992. His primary interest is in the care and treatment of HIV and its related infections. He also has been actively treating HIV-infected individuals for over 20 years. Dr. Keiser is chairman of the Texas AIDS Drug Assistance Program Advisory Board and principal investigator for the Texas-Oklahoma AIDS Education Center. Over the years, Dr. Keiser has been an investigator in over 50 HIV-related clinical trials. Since 2006, Dr. Keiser has been involved in the implementation and evaluation of the U.S. President's Emergency Plan for AIDS Relief and in HIV clinical care, teaching, and research in Kenya. His clinical research interests also focus on the treatment of HIV in resource-limited areas, antiretroviral therapy in HIV-infected patients, and also outcomes and cost-effectiveness studies related to HIV treatments. Dr. Keiser's career has placed him on the front lines of the world's battle against AIDS. We are delighted to have him with us today to share his story and update us on the efforts to eradicate this terrible disease. Please join me in welcoming UTMB's own Dr. Philip Keiser to the podium.
Thank you. I don't recognize myself when I hear that. It makes me sound so old, you know. I know, that's the problem. You see, I think of myself, you know, when I was your age, I was as skinny as you. And my hair was darker. And, you know, it's, you know what they say, time wounds all heals. You know, it has a way of catching up with you. Today, rather than give sort of an academic lecture, what I'd really like to do is kind of give you more an historical perspective on what happened with the HIV epidemic and what happened during the periods of time even before I went to medical school. And I'd like to, since this is supposedly a health policy dialogue, just kind of highlight a couple key policy issues that really have made a huge, huge difference with this disease, but also the difficulty in getting there, and then talk a little bit about where we're going in the future and what may realistically happen. So I started medical school in 1982. So that means I've kind of grown up with the HIV epidemic. And as I look back on my career has really followed the arc of the epidemic. And it's kind of, I'm getting to the point now, you know, for the longest time things were so bad, you know, we always despaired of curing the disease. But now I'm at a point in my life where, since we have a way of curing HCV, I'd like to cure a couple people with HIV before I retire, you know. I mean, I think that would be really cool. We're not quite there yet. I don't know if we really have anything that will do that yet. But I suspect that sometime, if not in my professional career, in your professional careers, you'll have the opportunity to do that. So let's see if we can get this thing going. There we go. In the late 70s and early 80s, doctors started seeing young men come with this. They had this blotch on them. They had these blotchy growths on them, which turned out to be a cancer. And it was actually a very rare cancer. It was a cancer called Kaposi sarcoma. Kaposi sarcoma was typically seen in middle-aged, elderly, Eastern European men and seen on their lower extremities. Except they were seeing it with young men, young gay men, and seeing it all over their body. And there were more cases. Some of them were horribly disfiguring. Sometimes people died from this. They didn't know what it was. No one knew why they were seeing it, but it was clearly clustered this. They saw lots of cases in New York and San Francisco and Los Angeles, and then scattered all across the country. And people were wondering, what is going on here? In addition, they started seeing pneumonia. This is a classic picture of what we call pneumocystis carinii, or actually pneumocystis jirovecii pneumonia. So for the medical students here, I mean, this is a classic picture. You see a diffuse interstitial infiltrate, right? It's not a classic lobar pneumonia. Back then, this was unusual. This was not common. What was it? What's going on? People were really wondering. And so a bunch of smart heads got together, and that great medical journal, the New York Times, first published it. Rare cancers seen in 41 homosexuals. Doctors in New York and California have diagnosed homosexual men 41 cases of a rare and oftenly rapidly fatal form of cancer. 8 of them died in less than 24 months after the diagnosis was made. And then later, in 1984, the CDC actually published the results of that. A cluster of capsicsarcoma and pneumocystis carinii pneumonia among homosexual male residents of Los Angeles and Range Counties, California. Something was going on. No one really knew what it was. No one knew what caused it. A lot of epidemiologic studies were done. And then after these epidemiologic studies were done, it was pretty clear this was a sexually transmitted disease. And in fact, they were able to trace about 50 of the first people that they could confirm had this illness, had either had sex or had sex with someone else who had had sex with one guy. That doesn't mean that this one guy caused the epidemic, but it just kind of shows you how these things clustered, and it was very clear this was a sexually transmitted disease and a sexually transmitted illness. After a long period of time, in 1984, it was discovered that this was a virus. This virus was a retrovirus. That means it's a kind of virus that actually, instead of having DNA as its genetic material, it has it in the form of RNA. And then it converts that RNA into DNA and then incorporates into the bloodstream. There had been several other viruses like this that had been found in humans. They're found all over the mammalian kingdom. And there have been several others that have been found in humans. But this was something a little different, because the ones that had been seen in humans before really didn't cause this type of illness. And it didn't cause it in such a wide fashion and such a wide range of things. And then in 1985, because they found the virus, they were able to do a blood test. Okay, now we're in great shape. Now we can actually figure out what's causing this virus. Now we can figure out what the epidemiology of it is. And so instead of just looking at people who have this cancer, this gay cancer, that's what they called it, gay cancer. They called it gay-related immune deficiency as well. We can actually now see how many people have it. And it turned out a lot more people were infected with this virus than anybody had ever realized. It wasn't localized to just a few gay men in New York City and in Los Angeles. It was all over the country. And after discovering that it was a virus, in 1985, some studies were done with this drug called AZT. See, enjoy AZT, right? But AZT was a drug that had been around for a long period of time. It was originally developed as an anti-cancer drug. And because it was an anti-cancer drug, it interfered with DNA synthesis. So a scientist at GlaxoSmithKline, actually that was Burroughs Wellcome at the time, took some of this AZT and put it in a test tube with this new virus, which now was being called LAV1, HTLV3, not quite yet HIV, but almost there. And it found out it killed it. Wow, that's great. Wow, this is great. So now what can we do? We can take this thing and we can turn it into a medication. So they did. And they came up with some pills. And they took people that had LAV/HTLV3/HIV, as it's now being called, and they gave it to them. So it was really hard to take. You had to take it 6 times a day. You had to wake up in the middle of the night to take it. It gave people severe nausea, vomiting, diarrhea. It made people very anemic. But guess what? It worked a little bit. People who got the drug lived longer. All right? Started people on AZT, they would live about 18 months longer than people who didn't get the drug. So in some ways, that was a real sense of hope. But listen to what I'm saying. You started on, you're going to live about 18 months longer. And we could predict that with certainty, be very certain that people would do this. So you can see things are moving forward very quickly. Disease first noticed in the early 80s, and then by the mid-80s, we have a test, and we have a drug. We should be in really good shape, right? But people kept dying. This is the death rate. And this shows you the death rate from, I think it's, 1987, right? And it just climbs. Why are all these people dying? Anybody know why they're dying? My hearing's poor. You got to speak louder. They're dying from infections, sure. Why are they getting infections? They're immunosuppressed. Why are they still immunosuppressed? AZT's not enough coverage, yeah. But if you actually look at the number of people who had AIDS versus the number of people who actually had HIV, very few people were getting treated. Okay? Access was a huge issue. How do we get access for these medications? First of all, AZT cost a ton of money. We talk about how much HIV medications cost now. That one pill cost almost $20,000 a year back in 1986. All right? So unless you were independently wealthy, you couldn't get it. Insurance companies didn't want to pay for it. This cost too much money. Hospitals didn't want to pay for it. Then people started doing things like, well, we'll have a pilot program. At Parkland Hospital, where I worked before I actually got there, they had a list of patients who could get AZT. And this was based on some sort of research study designed to test the cost effectiveness of the drug, blah, 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 blah. And unfortunately, the list kept changing, and the doctors, as we do when we don't like what our administration does, we'll kind of sneak people on who we think need to get on and rearrange the list and do all these sorts of things, and people were still dying. And finally, some HIV activists took them to federal court, and Judge Barefoot Sanders says this is nothing more than denial of care to American citizens based on their sexuality, and ruled it unconstitutional and ordered Parkland to start giving people HIV medication. They actually went to court 3 times, and they lost every single time. And what happened in Parkland was not unusual. It was happening all over the country at the time. In addition, the Reagan administration was not responding to the crisis. Reagan, it took him till 1989 to say the word AIDS. He didn't want to say it. It was because when you look at who gets AIDS, who got AIDS? It was gay men, primarily back then. But then African Americans, African American women, drug users, prostitutes. Draw a circle around mainstream society, everybody who falls on the margins of it. It was so bad, there was a joke that used to go around, what's the worst part of having HIV? Having to tell your mother that you're Haitian. People didn't want to deal with it. They didn't want to deal with the issues. They didn't want to deal with all the social issues that went around that. And then the gay community started to organize. And they developed groups. It started off with a group called the Gay Men's Health Crisis Center in New York City, which later turned into ACT UP. And these were basically gay men who went out and started protesting. And they started demanding that the government do something. And they would do crazy things like they closed down the National Institutes of Health. Can you imagine 10,000 guys like this coming in to the NIH parking lot? The guys can't park their cars, they can't get in the doors, and then they would all fall down and die. All right? They did this all over the country. They did it at Parkland, too. It drove the administrators absolutely crazy. They were terrified of these guys. They were absolutely terrified of them. And I remember during one ACT UP protest at Parkland where the president of the hospital and the vice president of the hospital, they're standing there kind of looking out the door. Oh, you shouldn't go out there. Nah, fine, I'm going to go out there. Looking out, all these guys lying on the ground. Hi, Dr. Keiser. How you doing? we're having a die-in. Yeah, I can see that. Make sure you come to clinic. Oh, don't worry, I'm going to see you next week. Okay, fine. But they made a big point in that they were not going to allow the government to ignore them and to treat them as second-class citizens and to continue to deny people what was potentially life-saving medications. Okay. Other groups organized to try and get medications in from other countries. So you've all heard of the Dallas Buyers Club. So I never knew Ron Woodruff, but I knew other people that were part of the Dallas Buyers Club. These guys would go to Mexico, and they would fill their trunks up with drugs that they could get from Mexico and bring them into the United States and then distribute them. As a doctor, it was really frustrating. I understood why they were doing it, but they were getting medications and they were getting side effects. We really didn't know what they were taking, and we really didn't know if they were pure drugs. But the FDA had such a slow process to approve medication, it was taking forever. Okay. Then you start seeing things like this. All of you see the pink ribbon, for breast cancer? So, all you young women, well, we did it first. You're stealing our ribbon, but that's okay. You can use it. All right. The concept of World AIDS Day. Let's have a day where we're really going to stop and talk about it. All right. Let's have a day where we can make some differences and make some change and really focus on this. And then the AIDS quilt. So what people would do is if they had a loved one who died from AIDS, they would make a quilt. And I really don't know how this got started. I think somebody just did it like to make quilts. And then other people started doing it. And before you know it, thousands upon thousands of quilts were made. And then people were taking them on the road and having sort of shows. And this shows the mall in Washington, D.C. You can see some people here handing a quilt. You can see the quilts there. All of these are individual quilts, all of about maybe 6 by 6 feet square. And they would all be very individualized. They would have the person's name, something personal about them. I went to see the quilt when it came through Dallas. And, in some ways, it's a very somber type of thing. And, you'd see people's names you recognize. You'd see some memorial of them or some little thing about them that would make you smile. And then there was this one quilt. Everybody stopped, and they started laughing hysterically. And that's because that was Ranger Slager's quilt. And Ranger was one of the most god-awful, obnoxious, annoying patients that anybody had ever known, and he drove us all crazy, and in the process, everybody kind of fell in love with him. And so, and you're sort of like, oh my God, Ranger, I thought I was through with you. And here you are at the AIDS quilt. And you would see people like that. Look at the numbers of people. Look at the numbers of people that were dying. It was very sobering time. And for the young people here, all I can say is this was our generation's Ebola. And a lot of us felt like we needed to do something. And we needed to do something about it. But even with this, things were very slow. Things weren't happening. Numbers of cases were increasing. And not only were the numbers of cases were increasing, we're finding out that this epidemic was a lot different than what we thought it was. We thought it was a bunch of gay men. And you see the gay activists, they're out there. They're protesting. They're exercising their civil rights. But when you start actually doing extensive testing, what you're finding is that the places that are affected the worst are really in the rural South. Okay? And this is where you're seeing most of the cases. And most of the cases you're seeing there are among African Americans, poor African Americans in the rural South, and mostly African American women, more women than men. Which turns out once you get to Africa, it's the same sort of thing. It's an interesting phenomenon. All right? And the epidemic just keeps growing and growing and growing, and not a lot's being done until this kid comes along. This is Ryan White. How many have heard of the Ryan White Care Act? Right? It's named after him. Ryan White was a boy with hemophilia. He got HIV through blood transfusions, made him, when he turned to be about 6 or 7 years old, he was diagnosed with AIDS. And when he was diagnosed with AIDS, they kicked him out of his public school. And he became sort of a cause célèbre for this disease. And in a very odd way, turned the hearts of Americans. Because instead of people all around the margins, all those kind of people that mainstream America doesn't necessarily like or really consider or just want to worry about, I mean, look at this kid, right? He's a nice, handsome, white kid, right? But the most important thing about Ryan White was really the content of his character. Because he turned out to be one of the most gracious, one of the most thoughtful spokesmen for what HIV was. And he was 12 and 13, 14 years old. And people admired him so much that finally people said, we really need to do something about it. And so by the end of the 80s, you see a huge wellspring of, we need to do something. And also what happened in 1988 was George Bush became president. So Reagan was out. George Bush was in. And suddenly several things happened. One, FDA said, okay, we're going to have a fast track for HIV drugs. Okay? We're going to put these drugs through because we realize this is a severe life-threatening illness. We need drugs rapidly. We're not going to make you go through the normal testing. We're going to have a different procedure. So instead of having to prove beyond a shadow of a doubt that things are safe and effective, if you can give us good evidence that this drug works, we're going to provisionally approve it. And then we're going to allow you to continue to do studies on the drug and allow people to have access to the drug while you're doing further studies with that. And that's what happened. So suddenly more drugs became available. In addition, Congress passed the Ryan White Care Act. And so they named this after Ryan White in honor of him. But also, what this did was this provided funding. Okay? This provided funding for people who are poor, who don't have access to medicine, who don't have insurance, which is the majority of people that have HIV, so they could get care. And this really was the big game changer in the United States. Suddenly you start seeing HIV clinics opening up all over the place. Suddenly you now have medication that you can treat patients with. Suddenly you now have blood tests that you can do to follow how patients are doing. And patients start coming in. And when they start getting treated, they're getting treated, and they're doing better, and they're doing better. And so this was really, I think, a real sea change. But I think it shows you how a lot of this stuff can happen or doesn't happen. None of this would have really happened if people had just kind of quietly sat back. Nothing. Look at the response to Zika that we're seeing, okay? Right? To consider Zika, and I'm not trying to downplay Zika in any way, shape, or form, but consider what are the healthcare consequences of Zika compared to the healthcare consequences of AIDS for the nation. It took the United States 10 years to come up with a funding thing. And with Zika, people were screaming because Congress didn't act last session, but did act this session. No, I'm not saying we should let Congress off the hook, because I don't think we should. But it just kind of shows you the fact that people weren't doing anything. And it really required activists and required grassroots efforts to get to the point where people who could make policy would start to make the policy or suggest the policy to legislators and executives so they would then act on it. All right? It took a long time. Despite the fact that we had the drugs and the new drugs, people were still dying from HIV. And we tried using one drug. We tried then using another drug. We would, as these new drugs came out, we would use serial medications, use one after another after another. And we can kind of extend people's lives a little longer, a little longer, a little longer. But at the end of the day, HIV was still a fatal illness, and people were still dying. So in the mid-1990s, this new class of drugs came out called HIV protease inhibitors. This is probably one of the first ones that showed a marked change in how people did. It was a protease inhibitor called ritonavir, a preliminary study of ritonavir, an HIV-1 protease inhibitor to treat HIV infection. And what was happening was absolutely remarkable. Patients were being treated with HIV protease inhibitors, and they were being treated with HIV protease inhibitors in combinations with other drugs. So if you use 3 drugs at a time, what happens? Well, turns out the amount of virus in people's blood went down to 0, or as best as we could tell, because our tests couldn't measure down to 0, but we couldn't find virus in people's blood anymore. And their immune system recovered, and they gained weight. And they stopped having infections. And they stopped dying. It was remarkable. 1996, and Clinton, you remember this. 1996 was a watershed year for us because we started treating these people and it was like, well, I have this new medicine. I want you to try it. Well, how's it going to work? Well, I'm not really sure. I mean, we have studies that say, and they would come back in and say, Doc, I feel so much better. Doc, I've gained a little weight. And then 6 months later, Doc, I'm getting fat. Right? And they were getting fat. Why are they getting fat? Well, because their body was just so eaten up with HIV and they were spending all their energy on fighting off this viral infection that when we stopped the viral replication, they could start putting on weight. And they felt so much better. And it affected mortality. This is what happened. Here you have 1994, 95, death rate increases, death rate increases, death rate increases, death rate increases. Boom. December 96 is when the first protease, 95, when the first protease inhibitor came out. Through 1996 and 1997, we spent so much of our efforts getting as many people on these drugs as we had. And look what happened to the death rate. Dropped like a stone. But then over subsequent years, what's happening? People still dying from AIDS at that period of time, right? And even today, in 2016, people still die from AIDS. And there are reasons for that. But at the time, it was in large part because we had these drugs, and the drugs worked, but they were really quite hard to give. This shows you a woman. She's actually African. She's not American. I couldn't find a good picture of someone who's an American, although they exist. You can see this is when she was totally wasted with HIV. This is several months after she started taking medication. This is a year later. It's remarkable. We call it the Lazarus syndrome or the Lazarus effect. You'd start treating people, they'd look like they were dead, and they would come back, and they would be absolutely fine. And it was absolutely remarkable. But the problem was you had to take a lot of pills. This looks to me like nelfinavir, 3-TC, and something else. But basically, this is a typical regimen in that period of time and what people would have to take. Okay, this is one dose, gang. All right, got to do that 3 times a day. Okay? All right, it's really hard. And not only that, the drugs had a lot of toxicities. Diarrhea, nausea, vomiting. Everybody was nauseated. Everybody had diarrhea. Some patients had very bizarre symptoms. With the first protease inhibitor I showed you, ritonavir, people would say, I feel like my hair's on fire. My teeth itch. I mean, they weren't kidding. They were really telling you this. I had one patient, and we would keep telling him, please keep taking it. Just give it another week. The symptoms will get less. Please keep taking it. Please keep taking it. And finally, one day, one patient come in and he goes, I hate you. And he meant it, because it was really hard. And so people had to spend all their life being patients, all right? Because they had to get the meds down. They had to go to their doctors. They had to do other things. And even though they were getting better, it was still really, really hard. And it was very, very difficult for patients. A major breakthrough that occurred over the next 5 years is this. This is a medication called atripla. I don't know why it is A, because it has 3 drugs in it. That's where the tripla is. So atripla means there's not 3 drugs? I don't know. Anyway, I can never figure out drug names. But this is where you could take a single pill once a day. And that is our current treatment paradigm. Because once you can take a single pill once a day, what happens? Instead of having to take a whole bunch of pills, you can take your 1 pill once a day. And if you take your 1 pill once a day, you take it and you're done. You have to take pills all day long, you miss pills. You start missing enough so that you're not suppressing the virus. You have drug in your bloodstream, but not enough to suppress the virus. The virus developed resistance, and the drugs stop working. And what was our solution to that? Well, we'll give you more medicine, except instead of 3 times a day, you're going to have to take it 4 times a day. And instead of 20 pills, you're going to have to take 40 pills. You see where this is going, right? And so it turns out, and this has been very well studied, the people who do the worst on HIV medicine aren't the people who never take their drugs. They're the people who can take it about 60 to 70% of the time. You know? They're getting there. They're close, but they're just not quite making it. And so then they develop resistance. And then we give them something that's harder. And they've already failed the first test, so we give them something harder, right? And then that doesn't work. And then eventually all the drugs stop working, and they eventually die. We no longer use this drug because we have stuff that's better. We have stuff that you can take 1 pill once a day that has fewer side effects than placebo when compared to a placebo in a placebo-controlled trust study. And that's pretty much what we use. And we use a class of drugs called integrase inhibitors in the second decade of the 21st century. And so people can do extremely well with HIV. That's what was going on in America. But during this whole period of time, people were ignoring what was going on around the world. And sometime in the late 90s, early 2000, late 90s, people woke up that, whoa, we have a huge epidemic in Africa. And that this epidemic makes what's going on in the United States look like nothing. All right? This just shows you the percentages of HIV prevalence at places across sub-Saharan Africa. So just to give you some form of reference, the HIV rate in the United States is about 0.1%. Okay, about 0.1% of the people in America. And there are about 1 million to 1.5 million people in the United States who have HIV infection. See the red? 20 to 39%. Okay? Think about it. A third of the people have HIV. 1, 2, 3, 1, 2, 3, 1, 2, 3, 1, 2, 3, 1, 2, 3, 1, 2, 3, 1, 2, 3, 1, 2, 3, 1, 2, 3, 1, 2, 3. Everybody look around you and count 1, 2, 3 around you. And then think that that person who's number 3, they're going to die, and there's nothing anybody can do about it. And not only are they going to die, they did die. And they died in droves. This is an estimate that was done by the UN of the effect of the of AIDS death on in sub-Saharan Africa. I'm sorry, actually in South Africa. Okay, so initially the deaths were about 50-50. Just stop and think about that. All right, half the deaths in your country are due to AIDS, and doing nothing meant that 90% of the deaths in the country were due to AIDS. Now, if you're a leader of a country and you're seeing that half of your people are going to die, what are you going to do about it? If you're the leader of the United States and you look around and you see there's a part of the world where you're going to see maybe half the people or more die from an early death because of this infection, what are you going to do about it? Think about the implications of that. What happens when you have epidemics? It causes political instability. It causes economic decline. So if nothing else, from your own self-interest, you would want to do something about it. And if you had any compassion, you'd really want to do something about it. This has been called the most important thing that George Bush ever did, which he will never be remembered for. And there's probably truth in that. You know, I mean, we're going to remember him for the wars. And we're going to remember him, you know, for what's still going on in the Middle East. Winston Churchill once said of Neville Chamberlain, "History shall not be kind to poor Neville, I know, for I shall write the history." And so I think whoever writes George Bush's history, you know, 50 years from now or 25 years from now, it's really going to change. But this is his real legacy. And so he wanted to do something about HIV. And so because of that, he brought people to the White House. And one of them, this is talking about a physician from Haiti called Jean Papet, and basically asked him for advice. What do we need to do? And then he very quietly started organizing and pushing through Congress a bill to fund HIV care across the world. In the 17 most affected 17 most affected countries across the world. And then, once he got the bill passed, he insisted that it not be politicized. He actually announced it in the State of the Union address in 2004. Most members of Congress hadn't heard about it. And for the Republicans who are going, well, why are we spending all this money on those people? He quietly twisted their arms and made them do it. And I got to say, when he was governor of Texas, when it came to HIV issues, as long as there was, we could have some consensus about things, he was very happy to put money into HIV care, unlike any governor before or since. So I think he genuinely wanted to do something about it. So with that, there was actually formed he put $50 billion US dollars. Let me say it again. $50 billion US dollars was put into a program in collaboration with the UN to develop HIV treatment programs. And from a public health point of view, it just kind of, we're talking about, how do you go about setting something like this up? They started off with these principles they called the 3 1s. And that there would be, instead of putting all this money in and letting a whole bunch of people do everything every which way they want, they were going to have some principles on the way that they would do it. There'd be one HIV action framework. There would be one coordinating council, and that in each country there would be one country group that would monitor and implement the program. And then they took what's called a public health approach. I mean, we're talking about public health here, right? So this is something that was a little difficult for me when I first got involved in it, because I'm a physician trained in the United States, and we're all about the individual. And we're all about making sure that individuals get the best care that they can. And, it's even in our creeds. We hold these truths to be self-evident that all men are created equal. And so if that's the case, then you have to give everybody the same, you have to, really focus on those individual freedoms and those individual liberties and individual health care. You go to Africa, they know that all men are not created equal, all right? It's a very different way of thinking. And so with that, there is a public health approach. And behind the idea behind a public health approach is, rather than figuring out what's best for you and what's best for you, what's best for you and best for you, we're going to figure out what's best for everybody, the majority of the people. And we're going to come up with an approach that we're going to treat as many people as we can successfully. And with that approach, there are going to be some people that will fall by the wayside, and that's simply the price you pay, all right, to treat everybody else. So with this, you have a standardized first-line regimen. This is something that's never heard of in the United States. You come to me, go to Dr. Kabata, go to Dr. White, you say, I want to get started on HIV care. We sit there and we look at all your labs, we look at your tests, we talk to you about some things. We say, well, I think this would be a really good drug for you. All right? That's what I would do. But Dr. Kabata will see the same patient and goes, no. I think this one will be a little bit better for you. And Dr. White might have a different opinion. And that's how we do things. That's the way we practice medicine in the United States. With the public health approach, it's nope, one single regimen. All right? What that does is that provides simplified training of providers. So now we're going to put $50 billion into treating people across sub-Saharan Africa and also Vietnam and Haiti. How are we going to train all these doctors? By this time, we have about 20 meds. Well, now I don't have to teach you about 20 meds. We're going to decide on one simplified approach. And I only need to teach you about 3 meds, because remember, we only use 3 drugs to treat people. All right? In addition, simplified monitoring for toxicity. I'm only using 3 drugs. I only have to monitor for the toxicities of those 3 drugs. And since I'm only monitoring for the toxicities of those 3 drugs, I don't need as many lab tests. What am I doing? I'm making it easier to train, I'm making it easier to implement, and I'm keeping costs down. All right? You can then have predictable management of resistance, limited numbers of drugs to procure and manage. And this turned out to be a huge issue, because we're starting people on HIV medicine, and you need to take that medicine, and you need to take it every day, and you need to not miss any. So I'm giving you HIV medicine. And then, the airplane crashed and your drug's not here. Your drugs didn't make it through customs. well, there's a problem with this factory in India, and so we're going to, you can't have that. And so the fewer drugs you have, you can manage the supply chain. And the supply chain for this project was crucial. And so it was important to make sure there were enough drugs on hand so that when we started someone on medication, there would be enough medication to continue to treat them, and that chain would go through so you could treat them for the rest of their lives. So the idea behind the scale-up was that initially there would be a lot of involvement from the United States and with less involvement from the host countries. And then over time, that involvement and money would go down, and that the host countries would eventually take over. So I started working with a group called AIDS Relief in 2007 and started traveling to Kenya. And this was a group that was specifically charged with rolling out HIV clinics in mission hospitals. And so for those of you who have never been to sub-Saharan Africa, what you'll find is that almost half the health care is provided by faith-based organizations. And this is legacies from, from colonialisms, and there were a lot of missionaries there. And then these hospitals were started, and many of these hospitals are still there and still providing care. Some of them provide really good care. Some of them provide pretty awful care. But our job was to go out and to set up clinics in these various hospitals. And the idea behind it was that you would have a clinic at a hospital, and then you start having regional nurses, and then you'd have what are called adherence officers. And these adherence officers are basically, they're lay people that have been trained in how to help people take their medicine. And then they would go out into the villages and work with folks. And then you have health workers, community health workers, have patients and families, and have support groups. And what you see is a big interaction there. And you've heard Hillary Clinton's book called It Takes a Village. And what that really is kind of referring to is the fact that in sub-Saharan Africa, the basic social unit is not the individual, it's the community. Okay? And so it's important then to work within groups and within groups of people, and to then facilitate people working together to take their medication. We'll get into that in a minute. So what would happen is that people would come in, they'd be diagnosed with HIV, and then they'd start undergoing training. We would train the patients, all right? We wouldn't just train the doctors, we would train the patients. And so what you see is you see a group of women here, and this woman who's standing up is talking to them about HIV, about how you get it, how you can keep from giving it to someone else, how you take your medicine, how it's important to take your medicine, why it's important to take your medicine, what are the consequences of not taking your medicine. What you can see is a couple things, is that, first of all, this is the hospital here. So you see the resources aren't very much. The folks aren't sitting on the ground because they like to sit on the ground. They're sitting on the ground because they don't have chairs for people to sit on. But you know what? That's okay, because they want to get on therapy, and this is important to them, and they're going to participate. The other thing you see, it's almost all women. Why do you think that is? Nobody knows? What? Women are smarter, yeah. Women generally, there's actually two reasons. One is a phenomena that is unique, I won't say unique, but it's common among areas where people get paid as day laborers, all right? So if you're a man and you're working in the field, if you don't go work in the field, you don't get paid that day, all right? So they tend not to come to clinic. They tend not to come and be seen. But on the other hand, just women are better about taking care of their health than men. I mean, how many times do you see some guy being dragged into clinic by his wife, right? How you doing? I'm fine. Oh, that's not right, doctor. He's not telling you something. He's like, shut up. Right? We see that all the time. But there actually is a discordance between men and women in terms of HIV in sub-Saharan Africa. It's about 60% women and about 40% men across the board. One of the things that's important to do in these programs is to do assessments of what people's homes were like. And so we would go into people's homes, and we would evaluate them to see what their home situation's like. It's very easy for me to give you a pill and say, here, take this with food. Take this before you go to bed. Set your alarm clock. Do you see an alarm clock? Right? So this is a shack. It's made out of tin. It's in a place called Naivasha. It's about 50 miles from Nairobi. Naivasha is known for its flower farms, And they have these huge flower farms there, which provide most of the fresh flowers for Europe. And so every day these flowers get cut and they get sent there. And this is a woman who lives there. She had these homes typically are, like I say, maybe about 10, 12 feet square. Often you'll have a dividing area between living room and bedroom. And some people are actually, they have really nice digs. You go inside and they've got a rug, they've got a divider between the living room and bedroom. They have a bedroom set, they have a living room set, they have a TV, they have satellite. You go and go, wow, this is really good. And then you see a woman like this. So her husband died, all right, probably from HIV. We don't know why. And so she's left there with her daughter. They sleep on the pallet on the floor. This is the greens you see there, something called squeamawiki. It's kale. And this is a sack of potatoes. And that's her main food, okay? And I've been into one home where all the woman had was a sack of potatoes. She slept on the potatoes, and she ate the potatoes. And so you see extreme poverty among the folks many folks who have HIV. But going into people's homes, you get a sense of what their living situation's like, and you're able to help them take their medicines. And this is a very typical way that people have their medicines taken. This is a woman who has HIV, and you can see her pill box there. And this is her, actually this guy's a trainee, but he's learning how to be a community health worker. And she's explaining to him how she takes her medicine. That's very important for her to explain, because that demonstrates she's taking it properly and she knows how to take it, all right? But not everybody does that. I saw one guy who we went into his house, and he wasn't taking all his meds because they actually count the pills. You taking all your meds? Oh, yeah. Having any problems? Nah. All right, well, let's see. Well, it's 2 weeks to your next appointment, and, on this one medication, you have 60 pills left. All right? Yeah, so what? We should only have about, 15 left or 20 left. He goes, well, no, I'm taking it all. And the guy's talking to him, gets out a whiteboard and does the arithmetic for him. It's like, well, and he's really not making an impact, and you can tell it's not getting anywhere. So, okay, fine. Well, you got an appointment in 2 weeks, so let's see. Your D4T, you've got 30 pills left for 2 weeks, that's fine. Here, I'm going to give you a couple extra in case you lose one. And your Nevirapine, you're short 1 or 2, so I'm going to give you a couple extra there. But your 3TC, here's 30. And they start taking the other pills away. The guy goes, what are you doing? You're taking my medicine. And the answer is, if you're not going to take it, we're going to give it to somebody who will. Wow, imagine that as a message, right? And the circumstances at the time, they could get away with that. We obviously can't do that in the United States, but for a lot of reasons. But imagine that message, If you're not going to take it, if you're not going to avail yourself of this, we're going to give it to somebody who will. So when I was working with AIDS Relief, we went around and we went all over the country and we were evaluating clinics. And some of the clinics were absolutely magnificent. We went to a place called North Kinnegop, which is in a place called the Aberdeen Mountains. It's a beautiful place up in the mountains, and they have mountain elephants that kind of wander through, and it's really cool. And it was run by this Italian priest, and he was the iron fist in the velvet glove. He basically, the place had they built all their own buildings, they grew their own food, they had their own water purification system, they had a clinic, they had consultants, they had labs, everything worked. We go in there, we go, wow. Yeah, we're going to start an HIV clinic here. And he was the kind of guy who, he'd walk around and he'd say, hey, how you doing? Everything going okay, Miguel? Yeah? Everything great? Yeah, good. Back to work. He would always be kind of friendly, and then there'd be this little back to work. And then we went to another place that was on the coast where it had been an Episcopal hospital, and literally the hospital was falling in on itself. The roof was like this, and it was caving in. And they had 2 doctors there. They had a young Kenyan doctor who just graduated from medical school, and they had this old British doctor or Scottish, and whose name was Donald. And he was 80 years old, and he was demented. And he was every conversation I had with him would end up with like, I was born in Tanganyika, not German Tanganyika, British Tanganyika. I don't know why my parents named me Donald. It's a pagan name, and we're Catholic. Why would they do that? You're laughing, and I'm going, oh my God, this guy's operating on women and doing C-sections. Oh my God! So I talked to Nate Smith, who was our team leader, and he was like, Phil, I understand what you're talking about here, but, with Donald, there are 2 doctors here. Without Donald, there's 1. And that's the situation in many cases. And the more I watched Dr. Donald, the more I realized that he was demented, but his hands were steady, and his eyes were clear. And I'm sure he had a ton of muscle memory, and that some charge nurse would just grab him and say, okay, Dr. Donald, here you go. You need to do a C-section on this woman. And he's there going, I wonder why my parents named me Donald. It's a pagan name, and I'm Catholic. There you go, love. I don't know what happened to him. But we would go in and we would evaluate them. We'd say, okay, these are what your needs are. You need help. You need another doctor. We'll pay for another doctor to come. You need help with your clinic. We'll help you do things. We can't pay for building, but we can pay for retrofitting. So we'll help you get the roof fixed. You're going to need help with your accounting, and we'll help bring an accountant in and teach you how to do the accounting so that you don't spend the money on things you're not supposed to. And what happened over time was that you see the numbers of cases or numbers of people being treated. And each one of those circles is the numbers of people being treated. And this is just over a 5-year period of time. You can see the numbers increase dramatically. And now there are literally probably 5 million people across the continent who are on therapy. And so when I first went to Kenya, I went there to help train people how to take care of HIV. Now when I go there, no one really cares what I think about HIV. They know what they're doing. What they want to know is, what do we do for all these people who are getting diabetes? They're all getting fat and gaining weight. And we need help with that. And so what do we do about our hospital infections? We really need help with that. But it's been an incredibly successful program. And this is just one of the first studies that have been done looking at a meta-analysis of the scale-up. And it basically asks, at 6 months, of the people that get started on antivirals, how many people are on it? And the answer is 80% of the people, for the most part, are still on drug at best case scenario. And these things where they did some worst case scenarios, turns out over time, not true. I mean, it's like this. There were a lot of naysayers who said, if you try to start HIV therapy in Africa, it won't work. People won't take it. Everything will go wrong. And boy, this program proved them wrong. This has been the most successful public health initiative that has ever been undertaken. And it has transformed healthcare in the continent. Because now, instead of thinking of things in episodic care, I'm sick, I have malaria, people are starting to think about primary care. People are thinking about chronic diseases. People are thinking about how are we going to do things. And it's whetted the Africans' taste, right? We've seen what can happen when we have money to do this. Let's start tackling other things. Let's start taking a systematic approach to doing things. And so, for the small part that I've had in this, I feel very privileged to have met some really wonderful, talented people, and I'm proud of the small part that I played in this effort. So, how are we doing with HIV in the United States? So this shows you the United States, where we are right now. All right? So remember, we stopped off right about here. People still dying from HIV. Look at the death rates. It continues to go down, 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 down. All right? Most of these people that are dying from HIV have access issues, they can't get into care, or they're not staying in care, they're not taking their medicine the way they should. All right? And so in the 21st century at this point, having people die from AIDS should be an unusual occurrence. And unfortunately, it's not unusual enough. And it's very frustrating to us when we're on the ID service and we have patients come in and they're not getting the proper care as an outpatient, and they come in very sick, and they have a bad outcome. But really, where we're going toward the future with HIV is to try and get the transmission rate down to 0. And this will be my last slide. And so there's an initiative in San Francisco called Getting to Zero, i.e. we want to get the HIV rates down to 0. How are they planning on doing this? Well, they do something called PrEP. And PrEP is, if I know I'm going to have sex, I'm going to take a pill, which will help keep me from getting HIV. And guess what? It actually works. Okay? Sounds crazy, but true. You can take some medication a day or 2 or several hours before you engage in sexual activity, and it will reduce the rate of HIV infection. Okay? The second thing is something called test and treat. So under the idea of test and treat, you go into a community and you test everybody at risk and then you test everybody, all their friends, and then you test all their neighbors, and you test their grandma. You test everybody. You'd be surprised how many grandmas have HIV. And as soon as you find out that they have HIV, you do what's called a rapid linkage to care. You get them into care as soon as you can, usually with 72 hours, and get them on meds. All right? And then so test and treat, and then rapid linkage to care. Now, San Francisco started this in 2013. In 2012, they had 494 new cases of HIV. In 2015, they had 255 cases of HIV. So this strategy seems to be working, and listen to what I say very carefully. This strategy seems to be working in San Francisco, but you have to put it in perspective, and the perspective is that they have a very well-organized community, they have a very strong health department, and they're geographically limited. San Francisco is on a peninsula, and so there's a high concentration of folks. You can get to them, and you can get them into care. Try imagining doing that in Houston or Dallas or any one of those metroplexes where you have a lot of different communities, different things. It may or may not work that way, but this is very encouraging. So what's happened to AIDS? Well, it's still here. People are still getting HIV. People are still dying. That's the bad news. The good news is that I can, instead of telling my patients, I'm going to give you this medicine, I'm not sure how it's going to do, I say, take this medicine. If you do exactly what I tell you to do, you're going to die an old man or an old lady in your bed from something else. And I want you to come to my funeral, and I plan on living a long time. You know? I want a big funeral. All right? So y'all come. You're all invited. Okay? And that's really cool, to be able to tell people that. And when people are really upset, you know, I've got AIDS, I'm going to die. So, yeah, you're not going to die. You know? I saw a woman in clinic last week. She has HIV. She has AIDS. She used to live on the streets, do crack cocaine, would often prostitute to make money for it. She's been clean for years. Her viral load's been undetectable. She has breast cancer. She has diabetes. She has renal failure. She's on dialysis. What's her biggest problem? HIV? No. And guess what? We're putting her on a list to get transplanted. Okay. So to me, her breast cancer and diabetes and renal failure, that's success, right? That's success. You have lived long enough so that you're suffering the problems that everyone normally faces. And we're going to address those too. So where are we with HIV? Still here? We're doing well? Do we have a cure yet? No. Would I like to cure a few people before I retire? Yeah, it'd be really great, but you know, we'll see what happens there. But I think we're in a pretty good place. And I think you can see how along the way, key people, as we talk about policy and we talk about legislation, made some very important decisions which made huge differences. And then when they didn't do that, things were terrible. So with that, I'll stop, take questions, comments, or if y'all got to go, that's fine too. Right on time. Nope. All right, go to. You're going to what? Be careful. Okay, all right, yeah. A little more, okay. Sure. All right, thank you. Thank you. Good to meet you.
This side of you, I just was pleased to hear that. We'll talk later.
Thank you. Thank you very much. Thank you.
Herd immunity, huh?
There's a yeah, that's the idea.
Getting the whole.
Get it. Yep. And there's even a concept called community viral load.
Yes.
Yeah, to get that down. Hi, Harry.
Keiser. Stephanie Jones.
Hi, how are you?
I just joined UTMB a little while ago in the fundraising
Mm-hmm.
development, but I've been involved with a lot of ad